Hello, everybody. Welcome. It is the top of the hour, and I want to make sure we respect your time. We'll give those who are wanting to join us just a couple more minutes here to trickle in. But I want to thank you again for joining us for our webinar today, Living with Ambiguous Loss in Multisystem Proteinopathies. We'll talk about the genetics, grief, and the lived experience of VCP disease. We're very excited to bring you this webinar today. We are a mixed bunch here today. We have myself, who's a genetic counselor, a social worker who's joined us, some members of the VCP disease community, as well as many team members at the Cure VCP disease organization. So we are a mixed bunch, in addition to you being our audience. So we want to thank you for your time, and we'll go ahead and jump into this content today. Okay, so just a little bit of background about who Cure VCP disease is and what we do. So we're a patient advocacy organization who really has a large initiative to discover a cure for diseases caused by the VCP disease or by VCP disease. And so as we'll talk about in today's presentation, you'll see VCP disease presents itself very differently across multiple families. And so we really have the drive and passion to make sure we can, discover a cure for these families who are impacted by this condition. So we were founded in 2018, and we are the only nonprofit in the world focused on the VCP gene mutation. And we have grown quite a bit over that time. We now have 7 members on our medical advisory board, 4 members on our drug discovery scientific board. We have a board of directors consisting of 8 individuals, and there are also now 2 people on staff. We do operate quite a robust registry with over 100 enrollees or participants across the world from various countries. And so we have a focus that can be broken down into kind of these 3 categories: patients and families, research, and clinical care. And so patients and families, there's a lot of opportunities through Cure VCP disease and our organization to offer connections for different patients and families through different care support groups and happy hours. We also lead a lot of research initiatives and foster collaborations with other scientists and researchers throughout the world. And lastly, we are here to serve as a resource to others looking to learn more about VCP disease, the clinical diagnosis, treatments, therapies, genetic testing, and everything as that evolves. And so I think there's really nothing better to kind of paint a picture of how all 3 of these come together than by sharing with you the standards of care that were developed. This is a large initiative led by our group. As you can see here, we've got 10, it took 10 working groups, over 50 clinical experts across 30 institutes in 8 countries. And this took a little over a year to complete. But we did develop this resource not only for clinicians, but also for patients and their families to bring to their care healthcare providers to better inform and standardize the care for those with VCP disease. And so I wanted to share this resource with you today, and I think it serves as a great example of how, really our focus comes together to generate resources like this for our community, along with so much more. And so today's presentation, I already alluded to this earlier, but we will have myself speaking. I'll speak a little bit to the genetics and clinical presentation of VCP disease. Then we'll hear from Tammy Scott, who is a social worker who's led many care partner and peer support groups for the VCP disease community. And lastly, we will hear from Olivia Parkinson, who is a VCP disease community member herself. And so today, the following speakers, or none of the speakers, have any relevant conflict of interest to disclose to you today, but we would like to take this time to gratefully acknowledge the Alexion Charitable Foundation for their financial support of this educational program. I will share that the content and educational objectives of today's webinar were developed independently from Alexion, and they were developed by the speakers you'll hear from today, excuse me. And so, but we do want to thank Alexion for their financial support, and that this presentation wouldn't have been possible without them. So the objectives for today's presentation. So first, we'll describe the genetic etiology and clinical features of multisystem proteinopathies using VCP disease as an example. Next, we'll define the concept of ambiguous loss as it applies to patients, care partners, and other support systems affected by multisystem proteinopathies. And lastly, we'll identify strategies that promote resilience and support healthy emotional responses to ambiguous loss. All right, so what are multisystem proteinopathies? I will admit that this is a condition or group of conditions that I was not well educated on during my genetic counseling training, and it's another reason why I'm glad we're here today. And so they are a group of dominantly inherited progressive disorders affecting the muscle, bone, and the nervous system. And they are quite heterogeneous in their presentation with variable expressivity, but they are a group of conditions that are united by their shared molecular pathophysiology, resulting in disrupted protein homeostasis. So I just threw a lot of words there at you, but we'll go through this if you're more a visual learner in one of the following slides with more of a diagram. But there are several key genes that are associated with multisystem proteinopathies and MSP-like phenotypes. That includes VCP and these other genes here, which I will not take the time to share the alphabet soup with you. But however, I do want to draw your attention to these are all important genes that should be assessed when considering a multisystem proteinopathy. And this list continues to grow as we learn more about the presentation of multisystem proteinopathies. But at this time, these are genes that are all going to be key genes in the MSP landscape. And so here's the image that I was alluding to. And so if you look to the left side of this image, you'll see the normal protein pathway that we normally have. So there are proteins that are used in our cells, but they're not always used in our cells. And this is a normal process for when a protein needs to be degraded or broken down. They are kind of flagged for degradation by the proteasome. And so this process is called ubiquitination. And so you've got VCP along with some other genes or proteins go through this process of resulting in proteins that need to be degraded. They're kind of flagged or ubiquitinated with this tag here. And so they're then broken down because of that flag. And this is a normal process that happens. It keeps our cells fresh, and it also makes sure that we don't have cells wasting energy on processes that we no longer need to complete. However, when we then have a mutation, let's say in the VCP gene or another multisystem proteinopathy gene, this process has a hard time going to completion. And so this process of ubiquitination happens, but it can't go to completion. This proteasome has a hard time breaking down the complexes. And so what happens is these complexes accumulate both in the cytoplasm, which is kind of the free space in the cell. They accumulate in the cytoplasm, and you can actually see this appear as what's called an inclusion body under a microscope in several cells. And so this buildup of compounds and complexes that should be degraded can cause and result in these various phenotypes, including inclusion body myopathy, myopathies, which is what you see here in the bottom right, and that name is derived from these inclusion bodies, right, that build up in the cells. But we also see, we've got the neurodegeneration and that presentation of multisystem proteinopathies, as well as Paget's disease of bone. And this happens actually because when these proteins and these complexes can't be broken down, it actually leads to activation of the osteoblasts, and then that causes Paget's disease of bone. So really, we've got quite, this pathway is quite disrupted and can lead to really a diverse phenotype, which we'll go through in the next few slides. And so MSPs should be considered in patients and families with one or more of the described phenotypes, including a myopathy, Paget's disease of bone, frontotemporal dementia, amyotrophic lateral sclerosis, otherwise known as ALS, a version of Charcot-Marie-Tooth disease in the axonal region, or spastic paraplegia. And so when you're going through and taking family histories, just be aware of any of these presentations and maybe think, could this be a multisystem proteinopathy if you see any family history of any of these conditions? Because genetic testing is the primary and definitive means for diagnosis of multisystem proteinopathies. So single gene testing, of course, is what's recommended for patients who have a known familial variant in an MSP gene. But multi-gene panel testing may be ordered for those with kind of a nonspecific phenotype or multiple presentation of these clinical symptoms. But I will make sure to caution you all is that when you go to order panel gene testing, that you review the panel content to make sure all of the genes that I listed on the previous slide, and will be on the next one as well, are included to make sure that you give this patient and their family the best chance at receiving a confirmed genetic diagnosis. So again, here are our MSP and MSP-like genes. I will say that they have the first 7 are clinically designated as a MSP. And so you might hear me throughout the rest of this presentation refer to use some terms interchangeably, such as VCP disease or MSP1, and those are the same thing. There are also a few other terms that we don't use much anymore, but those are one and the same. Some of the other genes are associated with other, or designated as other multisystem proteinopathies, as you can see here. And there are some common presentations. I won't go through all of these for the sake of time, but you can see there is quite an overlapping phenotype here in all of these MSPs. We see inclusion body myopathy, so that buildup of protein in the cells. We see patches of disease of bone, frontotemporal dementia across multiple of these multisystem proteinopathies. We also see in this one, and this is an interesting finding that we often see under a microscope. This is a certain type of myopathy that's seen associated with this gene, the rimmed vacuolar myopathy. And then there are some MSP-like genes as well that do have presentations that are similar to some of our other more classical MSP presentations, but they don't, right now, the current stage don't fall under just the MSP designation by itself. And so the VCP disease is the most common multisystem proteinopathy. And it is, as a result, the most well-described multisystem proteinopathy. I will say, though, just because it's the most common, though, doesn't mean it's not rare. So this is still a rare disease, but it is the most common out of all of these. And like I mentioned earlier, these last 2 genes are MSP-like genes, but they should still be included in any panel when sending out for testing when an MSP is suspected. All right, and so what is MSP1 or VCP disease? And so it is a heterogeneous disorder like we've already talked about. You've already seen some of the clinical presentation that I've talked about, but I will draw your attention to the lower left corner here, and that a large component of our disease presentation in our community is going to be that inclusion body myopathy, presenting in about 90% of those with a confirmed genetic diagnosis. We also frequently see Paget's disease of bone and frontotemporal dementia at about the same rates. And we can see sometimes an ALS presentation, a Parkinson's disease presentation, or a Charcot-Marie tooth. Remember, it's that axonal Charcot-Marie tooth presentation. And so what I will note here, too, is that these presentations are not always exclusive. Sometimes you can have more than one, but also you can see different presentations across different family members, although they have the same variant. And so MSP1 or VCP disease does have some other names like I've referred to today. Some others that you may have heard of in the past include just VCP-associated multisystem proteinopathy, which becomes a mouthful, or this longer term that combines all of the phenotypes, the inclusion body myopathy with Paget's disease of bone and frontotemporal dementia. So those are some older terms, but they might still be used on some other materials. There is no cure or treatment for VCP disease as a whole, and we'll touch on that a little bit later. And like I mentioned earlier, it is a rare disease, but it is the most common MSP. But there are an estimated less than 2,000 patients globally. And so this does affect the P97 gene, or the VCP gene as it's now named, and it is present in all tissues. And as we talked about earlier, this affects how proteins are degraded in the cells, and they build up and cause these different clinical presentations when they're not properly degraded. So we see several pathways affected, including autophagy or phagy, endosomal trafficking. I know this image is small here. some mitochondria-associated degradation, Golgi reassembly, so various cellular pathways are effective. And so why focus on VCP disease today? And so it is one of the best characterized MSPs because it is the most common. And so but it can also serve as a model for multi-system involvement across these different presentations. VCP disease highlights genetic variability. So there's variable penetrance and expressivity, as we've already discussed today. And there is also a strong clinical and community engagement through Cure VCP disease, through the Cure VCP disease community, which makes it useful for illustrating genetic counseling and psychosocial implications, such as caregiver and family impact, and ambiguous loss, like we'll be talking about today. And so I've already talked a good bit about, how multisystem proteinopathies do appear or do present themselves in these patients. But I want to draw your attention to this table that's in one of our publications. It's listed from some of the most common phenotypes to the more rare phenotypes. But I did want to list this table here to show that there are other more rare phenotypes associated with MSP1. And some that we haven't talked about includes respiratory dysfunction. We touched on a little bit Parkinson's disease, but sometimes we also see this condition called spastic paraplegia. There's rare cases of cardiomyopathy and some other dysphasias and other urinary and anal incontinence to be aware of. And so it really is quite a clinical spectrum when we look at MSPs. And what I want to also again mention is that the phenotype can look very different across families and even within families. And so these are all phenotypes to be aware of. So some genetic counseling considerations for VCP disease or MSP1. So as we discussed earlier, the mode of inheritance is autosomal dominant, but note that there have been de novo variants in the VCP disease or the VCP gene identified and reported. Genotype-phenotype correlation remains a major challenge in VCP disease for a couple of reasons. I will say most pathogenic variants are missense, so that is, something to be aware of. But there is a hot spot at the arginine 155 amino acid residue, where a lot of patients in the community have a mutation affecting this residue, and so that doesn't lend itself to a lot of, genetic variability that would lend itself to a genotype-phenotype study. It is an adult onset condition, and that's something I hadn't mentioned and probably should have mentioned earlier. It is adult onset condition, and we already have talked to great lengths about the variable expressivity and penetrance, and there's a broad range of progression even in different organ system involvement observed within families. And so given this vast disease heterogeneity, genetic counseling for VCP disease is truly vital. For multiple reasons, including providing predictive testing in asymptomatic individuals, providing opportunities for family planning and decision making around family planning or long-term care and monitoring. And this particularly can be helpful when maybe you have an FTD presentation when cognitive decline might affect that decision making. So genetic counseling really is critical for this community, and I can't drive that home more. And so across VCP disease, genetic testing is the primary and definitive means for diagnosis of all MSPs, but this also includes VCP disease. There are other ancillary testing that can be performed that can be helpful to inform a diagnosis, but none of these testing by themselves can provide a diagnosis other than a confirmed clinical genetic diagnosis. But sometimes it can be helpful to have an EMG performed, muscle biopsy. A nuclear bone scan remains the gold standard for diagnosing Paget's disease of bone, and of course neuropsych testing for FTD. So you may see some of this testing done throughout the diagnostic odyssey of diagnosing MSP1, but nonetheless I want to draw them to your attention. And so I do want to point out that, and we've already touched on it earlier, but there is no disease-modifying therapy currently available for those with VCP disease. And that is something that's very important to the Cure VCP disease community, and something they're working very hard to work towards. But at this time, there is no disease-modifying therapy, and that care is mostly supportive and multidisciplinary. I will note the bisphosphonates can be administered as a treatment for Paget's disease of bone. And patients who have taken this treatment or who are on this treatment do report improved symptoms and decreased pain, particularly bone pain, sorry, while taking this medication. It can be administered in an IV or in a tablet form. And so this can be a factor for some individuals and families when thinking about participating in genetic testing is that there is one medication if you have the Paget's presentation that can be helpful for improving quality of life. So that might be a consideration in participating in genetic testing for some. And that really management is a lot of surveillance across the multiple systems, right? Neurology, respiratory, cardiac, musculoskeletal, and cognitive function. And supportive therapies are also recommended across all of the specialties, including speech, physical, and occupational. And so at this time, I'm going to pass the mic over to Tammy, our social worker, who's going to talk to us today about what is ambiguous loss and why is that important to our VCP community.
Thanks, Ashley. Welcome, everyone. I just want to start off by saying I am a social worker by background and am part of the VCP community. And as we go through these slides, my intent is just kind of touch base on what is ambiguous loss, but also to get you thinking about from the patient and family perspective, how this will play into kind of how they present to you and interactions that you might all have with them. The other thing is I'll ask for a little bit of grace because I am used to specifically talking about VCP disease. And so I am transitioning over to MSP terminology. So as I go through these slides, I will try to incorporate MSP terminology in there, but some of them also talk about, chronic progressive diseases, because all of this does present to that. So jumping into this, what is ambiguous loss? It's really talking about all of these losses where you can't really define it. So lots of times we talk about loss related to death, but like the loss that a lot of our folks in these communities are talking about, you can't really put your finger on it. So it is unique, it's confusing, it's complex. It's hard for them to talk about, well, it's this, this is what I'm sad about, because really it's all of the things. Because this grief and this situation and what they're dealing with is prolonged. So, we're talking sometimes, even though Ashley said it's early onset or it's an adult onset, when we're talking with families, they've seen this generationally. And so lots of times it's in the back of their mind early on, before diagnosis, while they're trying to seek diagnosis. And so, that leads to what we call anticipatory grief. We don't have a diagnosis yet, but I'm already starting to grieve all of these things that I see or that I fear, for myself or my family member, or that they won't be along. So that's kind of, the beginning of ambiguous loss. And I do want to give credit to Pauline Boss, PhD. This is a term that she, was the champion for. And so of all the research, I'm going to give her huge props and credit because this is a lot of her work. This was her lifelong work talking about this that not a lot of other clinicians have talked about. So next slide, please. Okay, so how does ambiguous loss differ from other losses? The primary thing, and we'll see this in a lot of slides, is there's no death. There's no like concrete start and end to this. It is, all of these things. They lack certainty in what the future holds, what kind of the condition will be. They won't ever return to the way they used to be. So sometimes when we're dealing with a clear-cut loss like death, when somebody passes away, we have a funeral. We all come together. There might be a visitation or a wake, and there's a funeral, and there's a clear-cut thing that happened. People send cards, they send casseroles, they check in on you. With something like this is not anything that our communities know how to deal with because this is prolonged. This is, oh, you might have this diagnosis or somebody in your family has this. But when we're talking about, this is going on for years and years and years, there's no cultural rituals around that because it's still there. And so there's not a recognition of what to do for this. There's not a start and a stop. And so that's what makes ambiguous loss so different from other losses, that are related to death. Because it's prolonged, because it's chronic, because there's no stop and end to it, it's confusing for families and really a lot of those of us around it. And because it's prolonged, there's no resolution. You are kind of stuck in this grief process over and over and over. And so we see and often talk about the 5 stages of grief from Kubler-Ross. These do not apply to VCP disease or, MSPs, again, because we don't have that death that marks like the end of one stage and the start of another. So, just something to keep in mind when you're talking with folks and others, they might say, oh, well, you're going through the grieving process and there's 5 stages of grief. Understand that that doesn't necessarily apply to these MSPs because we don't have that death that then sparks those stages of grief. So, and I've touched on this a little bit, and I'm going to kind of keep beating this like a dead horse because that is like a, the main concept that I want to convey when we're talking about folks that are either have this diagnosis or care partners, family members, support folks, this chronic cascading loss, this prolonged grief process, long before they will ever come to you for genetic counseling, because we're seeing this generationally, they've already seen it, whether they've experienced it for themselves or whether they've experienced it through their family member that they've watched do this slow chronic decline. They're experiencing loss and they experience it over and over again and newly every time it happens. So it can be in the realm of, well, we used to take 3-mile walks. We used to be marathon runners. We used to do this for physical activity. And now, okay, now it's a 1-mile walk. That's a loss. Now we're not doing 1-mile walks. And to get to the mailbox, we're using a walker. That's a loss. Those keep adding up and they keep going. And you don't get over the last one because the next one is right there and it's over and over and over again. And this plays out not just in those things, but like going to family dinners, having kids, all of these things that we have general expectations for our lives. Every time those don't happen, or that anticipatory grief of every time you know it's not going to happen, that's a new loss that everybody is experiencing, whether that they are the patient or the loved one or anything. So that's why this is so important to keep in mind for you all, that this is happening long before they show up in your office for any kind of counseling. So some examples of ambiguous loss, and I want to call out here that in our normal non-diagnosis lives, we all experience ambiguous loss. And so we have that as part of our, aging process. And then you compound that with an MSP diagnosis. So the loss of a body part, the shift in what your mind or body can do, the dementia, brain injury, the physical decline that's related to all of these things. But in addition to that, a lot of us experience this in normal life, a divorce, moving away from your town, moving away from family and friends, becoming empty nesters that everybody talks and jokes about. Oh, isn't this fun? And especially like right now in the holiday time, you know, becoming an empty nester is an ambiguous loss. You still have children, but they may be adults. They didn't come home. Retirement. So all of these things are part of normal life. But then our folks in these communities are dealing with all of that. And then when folks are coming home for the holidays, they can't prepare families because they don't have the energy or they don't have the pain, they don't have the strength. So all of these things are examples of ambiguous loss. It's, Pauline Boss, if you read anything she says, if you listen to anything, it's leaving without goodbye because those things are just gone. They're still here. Or it's goodbye without leaving. You're sitting right here in front of me, but it's not the same. And so that's what ambiguous loss is. The feelings that go along with this, anxiety, helplessness, hopelessness. If we talk to our community about it and I don't present any of these, they will identify all of these as the feelings that go along with this loss that compound on top of their physical condition of what they're dealing with. So, frozen grief, you know, they are sad consistently and regularly. They're angry, confused identity. Who are they now? Ambivalence about all the things. So we're taking it from, you know, pre-diagnosis to diagnosis to, experience all these things, the feelings that go along with it. So this is things that either the patient or their family members can present in your office with. So I want to kind of shift now to maybe hopefully instilling a different way to think about all of this and maybe some hope. Because for a lot of folks, when they actually get the diagnosis, it can be crushing. These are not, as it's mentioned, there's no cure for this. There's no treatment for this. And so sometimes, when you get the diagnosis, everything's very black and white. But I want to introduce this idea of both and thinking. You can hold two contradictory things. They are both here and gone. And so, on the spectrum of truth, both of those can be true. You can be here and you can be gone. You can both have this diagnosis, yet live a full life. And so by acknowledging kind of the both and, it moves from these concrete black and white to all of the things in between. So I must find a way to both let go of these dreams that I thought I was going to have to continue to be an ultra runner, an ultra marathon runner, and yet, hold on to the things that are important to me and how I can have a fulfilling life. So that's kind of the concept of both and thinking. Next slide, please. The way that this can be applied, and you'll have to use clinical judgment as to whether you think that the person that you're meeting with is able to start hearing this because there is, that grief still is present. Um, and so, but just for you all to begin thinking, okay, how do I make this and introduce kind of this gray area? It's sadness and gratitude. I am sad, but, I have gratitude that I now have a diagnosis. A lot of our folks have gone through misdiagnosis for years. It's just this, oh, you're tired, and so it's really a long road to get to your office to get genetic testing to confirm this diagnosis. So some people will be relieved when they get this diagnosis. Now we know what we're dealing with. And so that both and thinking allows you to have both. I'm really scared about what this is going to look like for me, but I'm hopeful now that I've got a diagnosis and there's Cure VCP community behind me and we're looking for, cures, we're looking for treatments, we're doing these. And so even in your discussions with them, you could even model this and frame that. You might be grieving because of what this means, but there also might be some relief that now we know what you're dealing with, and we can connect you with these resources. So there's kind of some things that you can do in your discussions with them. Again, not just patient, but patient, family, loved ones, all of that to begin to introduce this concept of it's not black and white, it's not one or the other. There's a lot of gray area in between. This also relates to how they plan for the future, um, because you want them to plan for the future, but live in the present. There's some practical things that they need to do and getting their lives in order, all of their ducks in a row, finances, insurance, all of those things. So as you're talking about resources, again, this is a good way to kind of talk in between of, it's not just planning for end of life, there's life left to be lived. So as you're talking through these things and you're doing the counseling, try to introduce those gray areas of, how do you where are the areas that you're going to need support? What areas are you wanting to really maintain that independence, and how do we help you get there? Also want you to think of, scientific hat here. Genetic counselors, this is all very scientifically based in these diagnoses, in the testing, in all of these things. So if you yourself are a very finite thinker and it is very black and white, this might be a shift for you. And so I want to call that out because that shift, if you're hanging on to this, well, it's a diagnosis, it's this, that can be hard for you as clinicians to kind of see that gray area. So I want to challenge you if you are one of those people that is very finite, that, it might take a little bit of practice in figuring out, okay, what would that mean for somebody? And how could I reframe this, or how could I introduce these concepts and challenge yourself in how you see these things? Because again, it's not one or the other. There's all that gray area that we need to help introduce for them or model for them of how they cope with this diagnosis and how they plan for their future. So taking that a step further, Pauline Boss outlined 6 ways for building resiliency and living with or thriving through ambiguous loss. So I'm not going to go into each of these in depth, but I want you to know that there is hope out there. There is a way to deal with this loss and to still have a full, thriving life. So, first guideline is find meaning. So rather than just focusing on the diagnosis and what that means, you know, where can where can patients find meaning or make sense of this? Some of these things are nonsensible. There is no good explanation for why we have this disease. There's no good explanation for why some people are affected by it and others aren't. But where can they look in their lives to find meaning? I'll point out are the founders of our organization. This is meaning to them. This is what they did. A lot of us that support this organization, that's what we do. Adjust mastery. Okay. So, what is your new reality, and how can you now become, involved in something else to keep that reality and become trained in something else? They might have to reconstruct their identity. If they were a marathon runner and that's no longer acceptable, that's no longer viable, who are they now? What can they do? Slide. Normalize ambivalence. Just call it out and say, hey, we don't know. This is this is all that in between stage. It is normal to be happy 1 minute and sad the next. It's completely okay. Revising our attachments. If somebody was, we talk about, motherhood. If I was, one of these normal ambiguous losses, if I was a stay-at-home mom and all of my life revolved around raising my children, a normal way to deal with that is figuring out what's next for me. What's my new attachment? What do I need to move my life forward for? And then also new hope. Where do I see hope for my future, my family's future, this community, and where can I find hope in that? So, real quickly, ambiguous loss is not death, it's not prolonged grief, and it's not complicated grief disorder. It is not the same as PTSD because we don't have a post. This is ongoing. So, I'm just going to touch on those real high level and move on. So, because I want Olivia to have some time to speak. So, that just wanted to call that out. And as I touched on before, this is very different than grief and Kubler-Ross's grief cycle because we don't have that death. So, as you're talking to patients, it's lots of times it's really easy to talk about grief in this big, you know, realm of all grief is the same. It is not because there's no death that kind of sparks that. And that grieving then it shows up every day in all these different ambiguous losses. That's why as we go into the next slide, closure is not something that we generally talk about with this community because we're talking about relationships and we don't ever, and even with death, we don't want that relationship to end. And just even when somebody passes away, it doesn't mean that our relationship and our connection to them is over. We don't want to shut the door on that. So, as you're talking with folks and you say, well, I'm sure that you want closure. A lot of times we're not looking for closure. We do want to hang on to these relationships. And so just kind of be mindful of using that term. And in summary, all of these things, MSPs, these are chronic, prolonged losses for our communities, for our patients, for our families. By understanding it and kind of keeping it in this framework of loss, and thinking and these pillars for coping and finding hope. If you can adopt some of those and model some of those for the folks that you're meeting with, hopefully that can begin to introduce them to these concepts rather than this very black and white concrete philosophy that we often think in. So I hope that this has been helpful, and I'm really excited to hear Olivia kind of pull things together for us and give her experience with this community. So I'll pass it over to Olivia.
Thank you so much, Tammy, and thank you so much for discussing this. You actually were the first person who introduced me to the concept of ambiguous loss, and it's been really helpful for me to view VCP through that lens. So just for everybody else here, like they said, I'm Olivia Parkinson, and I'm part of the Cure VCP community, and I'm part of a VCP family. My dad is the family member that I have that's currently affected, and he primarily has the inclusion body myopathy presentation. So, my dad's slowly been losing mobility and had progressive weakness. And something I want to touch on too is my dad is not the first person in our family to have VCP disease. He's just the first person to get a VCP diagnosis. My grandfather and my great-grandfather both died from complications of VCP. They had different presentations and had very different pathways with it. But, in discussing with my dad what I wanted to talk about today, he shared with me that he's had similar fears to me where, because he saw his dad live with this throughout, my dad's whole life, throughout his whole childhood, it was always in the back of my dad's mind that, it might happen to him. Because my grandfather and great-grandfather both passed away before genetic testing was available. My grandfather passed away back in the 90s. So before, we even knew what the VCP gene was, before the Human Genome Project was completed, anything like that. My grandfather was given a misdiagnosis, and we didn't know that for 20 years after he died because we just didn't have the data until my dad finally got his VCP diagnosis. And, because of my grandfather's misdiagnosis, my dad was told that it was a very, very slim chance that he would ever have symptoms. But, it still lives in the back of your mind. It's this anxious fear of seeing something terrible and uncontrollable happen to someone that you love. Sorry, excuse me. But also not just being afraid of it for them, but being afraid that it will happen to you too. And so that's part of this. And, for me, my dad has VCP disease. And when he got his diagnosis, I decided to do genetic testing as well. And I have the VCP variant. that my dad has. So, it's put me in a little bit of a superposition of being a family member, watching my dad go through this, and also knowing that, for lack of a better phrase, I am also kind of staring down the barrel of VCP myself. That, I should have 10 or 15 years at least before I start having symptoms, but it does, having my diagnosis has also impacted my life, where it's kind of emboldened all of my anxious, intrusive thoughts of, anytime I drop my keys, anytime I trip over nothing, there's this little voice in the back of my brain that goes, hey, what if this is the first thing? And that's really tricky to deal with. And, for right now, I know that I don't have symptoms yet. And I know that I won't have symptoms for a long time. So I almost have to live in this state of active denial for my anxiety, to not let my brain, let me spiral every day, because I simply can't let that be where my energy goes. But the ambiguous loss piece of this is, I think, really, really important for VCP disease. I was a teenager. I was in high school when my dad started having symptoms, somewhere, I think 10 or 12 years ago, somewhere around there. And, that was really hard to deal with because, I was dealing with my dad starting to have progressive symptoms, and we didn't have a diagnosis for the first 5 years that my dad had symptoms. We had no idea what it was that was actually causing it. And getting a diagnosis was really helpful because it finally provided a name, and it provided this community of people who understood this progression in this disease. But in those years beforehand, there was still this loss. I just didn't know what it was. And, that loss happened, like Tammy touched on. Ambiguous loss is going on throughout all of the rest of your life. Like I said, I was in high school when it started for my dad. So I went through my first breakup, my high school graduation, my college graduation, all of these things, while also dealing with the ambiguous loss from VCP disease. And, I met my husband, we got married, all of this while dealing with it. And it's hard because, life goes fast and there's so many things that come at you. And having all of that while also having this undercurrent of long-term chronic illness that can't be treated and can't be prevented in any way. And there's other big things too. So, my dad got his diagnosis back in 2020, when, there was a global pandemic that was, just making everybody a little crazy, and everybody was worried about their health. But there was this undercurrent too of that's when my dad got diagnosed. That's when I did my genetic testing, and I was dealing with my own health issues at the same time too. That took, I'd been dealing with a chronic pain condition for almost a decade at that point, and was finally getting management for that. But dealing with all of that and a pandemic and my dad's diagnosis, all of this while still having work, and I was in college at the same time. That's everything about VCP is just as hard as dealing with any kind of loss, any kind of concrete grief, like a death of a family member, except it's so spread out that you don't even recognize when every single loss happens, because it's really easy to tell when something is the first. You remember when your kids take their first steps, when they say their first words, but you don't know when people have their lasts, because you just simply can't know it's the last time when it's the last time. And so that's something I really struggled with for a long time. And, I know my dad's planning to watch this recording later. But so Dad, I hope this is okay to say, but there was a couple years there where it was kind of difficult for me to interact with my dad, because it wasn't that I didn't love him, because I do. My dad is one of my favorite people on the planet. But it was really hard to see him losing things that were important to him. And it was really hard to worry about what was happening to him, and to have my genetic tests and know that this is part of my future. And I'm really glad that I am in a place where it's no longer difficult for me to hang out with my dad. It's no longer the primary thing, I think, when I'm hanging out with him. I have reached a point of dealing with some of this ambiguous loss where, I know that I can't know when the lasts will happen. My dad he makes incredible mashed potatoes. So that's his thing at Thanksgiving every year, is he makes the mashed potatoes. And I know that that's not something he's going to be capable of doing forever, because it takes a lot of work to have the arm strength to mash the potatoes by hand. But, it's something that, instead of feeling so sad every time I think about, like, oh, I might not get to eat my dad's mashed potatoes anymore, it's something that I can think that and also reframe it as, like, okay, I don't know how many times I have left of this, so I want to appreciate it while I do have these. That, I can show up to Thanksgiving and remember that this is something I want to cherish while I have it. So while VCP is really difficult to deal with, and while it is this pervasive chronic loss that's happening during everything else in life, it also, I don't know, it sounds a little cheesy and cliche, but it does make you appreciate the time you have. It makes you stop and, like, stop taking things for granted. Once you're able to get to a point with this ambiguous loss, once you're able to start getting through some of the immediate feelings that are that pop up, that are so hard to navigate, that feel like you're just being thrown under the waves and you can't come up for air, once you finally get your breath back in you, it's a little easier to manage. But I don't know. Sorry, I know I'm rambling a little bit. I don't know exactly where I'm going with this, but I don't know. VCP is a really unique disease. And I don't know. I think my experience with it is a little different than everyone's, because everyone's going to have their own path. I have two sisters as well that, they've been dealing with VCP very differently than me. And sometimes I think our own management of it drives each other crazy. I chose to do genetic testing. They've both chosen not to. And that's something I think sometimes I feel like they're crazy for not wanting to know. And I think sometimes they think I'm crazy for wanting to know. But we all just have different needs with it. But it really is such a unique journey. And I don't know, it affects everybody in a VCP family, but it affects us all so differently. But we're all still experiencing the ambiguous loss. It's just that we're experiencing different parts of the loss at the same times. I don't want to go over time, so
Wow. I don't know how to transition, Olivia, from everything you just shared. I mean, I want to appreciate and acknowledge, like, the vulnerability and sharing everything that you did with us today. I think we all have a lot to learn from your experience, your dad's experience, even that of your sisters, right? You've all had such a different experience, and it's impacted you and your family in such vast measures. And I think you really illustrated in sharing with us a lot of what Tammy shared with us today, right? Maybe been a process, right? We've applied a lot of that both and thinking, right? And probably
Yeah.
every day is still difficult to accept both and, right?
Yeah, absolutely. And, there's days where it's really, really difficult, where it feels like it's really fresh all over again, even though I would say at this point, 10 years after my dad's onset of symptoms, I feel not as like strongly buffeted by it every day, but there are still days that just hit you out of nowhere, um, that can be really hard to deal with because you're not anticipating them.
Of course.
But yeah. um
So, Ashley, hi.
Yeah.
I wanted to acknowledge there's a great question. And by the way, I'm Allison Peck. I'm one of the co-founders of Cure VCP Disease, and I just want to thank everyone for coming today. I want to Olivia, thank you, Tammy, Ashley. You've done a phenomenal job. But I thought that maybe we'd want to answer this question in the chat out loud. Do you have any recommendations for genetic counselors for pre-symptomatic?
Yeah, I think that's a great question and something that as an organization, I think we could probably think about building out a resource for. So stay plugged in to make sure there's a resource. But I think, right, a lot of the things to consider are, really any consideration we have for an adult onset condition and pre-symptomatic testing, right? We want to think about GINA specifically and those protections that are, protected for those against certain discrimination, but that there is not protection against consideration of genetic testing results for determination for life insurance, long-term disability, and care, and short-term disability. So we want to make sure to bring those up in discussion when having a conversation with someone thinking about pre-symptomatic genetic testing, and making sure that those, if those are policies and programs that the individuals are interested in, that those may be set up before participating in genetic testing. Other considerations for those in the pre-symptomatic testing realm may also be, is there any family planning that you want to discuss? How might this impact, your current life stage, right, with education, job, and any of those big life events, definitely let the patient who's in your office guide that conversation, but those can be additional considerations, right? Proximity, where do you live? So will you have help and support? Those are some things that we've heard from our community members that you would want to think about.
There's one other thing that I would add.
Sure.
Really, it's a personal choice for what each patient wants to do, and it's a journey for them. But just I mean, I think the guidelines put out is, explain the risks, explain the potential benefits, and then there's patient autonomy on deciding whether or not they're ready for it or not. And then also make sure that they have plugged into support afterwards, because it's a process.
Yeah. Absolutely. And I see we have another question in the chat, and then I'll answer that very briefly, and then we'll move on to making sure the CEU information can be presented. Is that the question in the chat, which just disappeared, is, will a parent getting genetic testing affect children's ability to get disability insurance? And that's it depends how deeply disability insurance would dig. If there's a, quote, family history of any condition, sometimes it's taken into consideration when getting disability insurance. It depends on how much you disclose also at the time of, applying for this disability insurance. But, your own participation in genetic testing shouldn't, or decision to or not to, should not affect, or it's not protected, sorry, against that disability insurance. So it's a tricky question. It kind of depends. And so we are at the top of the hour. We've had such a wonderful discussion. I feel so sorry to cut this short, but I want to make sure we I want to share some resources with you. And so there are some practice relevant resources on the Cure VCP Disease website. There's a link to a publication here that gives a good overview of a lot of what we've talked about today. We also have a new family guide, an updated family guide to genetic testing for the VCP gene available on our website. It's intended to be patient and provider friendly, so please feel free to take a look at that and share it with families. Lastly, I'll draw your attention to here on the same page. This is under for patients or clinicians under genetic testing, but we have a stipend that's available through the end of the year to help cover the cost of genetic counseling and testing expenses not covered by insurance for folks in our VCP community. We hope to extend this financial support for our community beyond the end of the year, but it is available through the end of the year. And so there is that available. And so then lastly, here is a QR code for the post-webinar evaluation and assessment. I'll go ahead and drop as well the, if I can pull up the chat, I'll drop this survey in the chat as well, which is not in my clipboard like I had planned. So we'll follow up by email. Hopefully you can take a look at this survey link or scan the QR code. And again, please complete this within the week to receive CEU credit for this year. I thank Tammy and Olivia, Allison, Brandon for being here, for sharing and contributing, and thank you all for your time today.